guys. Hello, hello, hello. Happy Sunday. It's me, Dr. Cindy Duke, Medical Director, Laboratory Director, and Physician at the Nevada Fertility Institute located in Sun Nevada. I'm also a PhD trained virologist, a PhD in microbiology and immunology, having my studies on viruses and vaccine development for viruses. Today, we have a very special guest joining us to talk all about not just coronavirus, but specifically coronavirus in the Caribbean and its impact within the community as it relates to diabetes, stroke, and other non-communicable disorders. As you guys heard last Sunday when we spoke to Barbadian-born Dr. Kelly, now based in Atlanta, diabetes affects here in the United States almost 133 million people are affected by either diabetes or pre-diabetes. Well, in the Caribbean, diabetes also has an impact, and we'll be talking with Dr. Gerard Antione today. I know Dr. Antione, he's actually a friend and colleague, but he's also a trailblazer. And so I'm actually gonna bring him on screen so that we can talk to him and learn more. Hello, Dr. Antione, how are you?
How you doing, Dr. Cindy? It's weird calling you Dr. Cindy because I am so used to calling you Dr. Duke, but I can call you Dr. Cindy.
I know, I evolved into being Dr. Cindy. So, Gerard, Dr. Antione, what's nice here is I've known you now since 2014. And as I was preparing for this, actually, I was like, how did we meet again? Because I've worked pretty closely with you. I've been working with you on your Caribbean medical providers practicing abroad. I've worked with you on so many things, but I think let's reintroduce you, not just to me, but to the world.
Awesome.
Who are you?
Well, I'm easy. I'm good. I'm not that special. So thanks. First of all, I should say thank you for having me on your show, because I have a large following here. So a little bit about me. I'm from Trinidad and Tobago, but I'm from Arima in Trinidad. I tell people I'm from Arima, and I went to Holy Cross College on Calvary Hill in Arima, one of the best secondary school in Trinidad and Tobago. I get a lot of flack for that. I think it's the secondary school in Trinidad. You're from Tobago, so you think differently. I'm also from Canal Street, but I grew up on Temple Street in Trinidad. Yeah, to me, it's a beautiful place. It still is, and some challenges these days. But I joined the Army at age 17, the U.S. Army, and I spent 31 years in the U.S. Army.
Yes,
yeah, it's incredible. I did a couple tours in Iraq and Afghanistan as a physician. I was a combat medic for a long time. I was also a respiratory therapist prior to going to medical school. And I retired after 31 years. My last deployment in Afghanistan was a bit much. So I was like, you know what? I've had enough. It's time. When you've had enough, it's time to come back.
Yeah.
I decided to come back to Trinidad, and as a physiatrist, which is a physical medicine and rehab physician, I came back home and I started the Stroke and Diabetes Center. However, but how we met was when I did the Caribbean Medical Providers Practicing Abroad. It's a 501c3 nonprofit organizations where we bring doctors, not only Caribbean doctors, but any doctor who wants to serve in the Caribbean, and we bring them back to serve our Caribbean, get in contact with, touch base with our Caribbean colleagues, so we can serve and share experiences and an opportunity and an effort to improve healthcare throughout the Caribbean and also throughout the world. I think if you do your little piece, that's your opportunity to save the world. I've been doing this since I was 17. I was a combat medic as a teenager, walking around with the first infantry guys. So I've been doing this for a long time. And
I've come to know you so well, and I've been so impressed because you're someone who, once you say you're going to do something, you follow through. And I have to say, for me, that was mentorship. I met you while I was still a fellow, and I talked to you about what my goals were and my dreams for practicing both within the United States and internationally. And you were like, do it, and you're like, I have an opportunity, use my vehicle, join this Caribbean Medical Providers Practicing Abroad and do it. And you've made that opportunity available to any and everyone who was qualified and willing to serve. And I think that's a testament to just how much you care. Now, for those listening, because your decision to go back home, you didn't have to go back to Trinidad and Tobago. As a matter of fact, you had a really good life in Hawaii. That's where I met you. I met you in Hawaii. I was there. That's how I met you, because I was like, how did I meet Gerard? I was in Hawaii for a conference for American Society of Reproductive Medicine, and I got in contact with you, and you were like, I live out here, and you met me at the hotel, and that's where we first talked about the plan. And at the time, you were telling me that in so much as you love Hawaii, you really feel like something's missing, and you told me about your mom's story, maternal health, and wanting to go back to do more for stroke, diabetes, and rehab. And that, of course, drove how you train. So you were a respiratory therapist. Tell us what that is. And of course, in the age of COVID-19, that's a big deal. What is a respiratory therapist?
Well, initially I was a combat medic.
Yeah.
So we progressed through the ranks in the United States military in order to get promoted. And as my confidence grew in academia and academics, I wanted to be something a little more challenging. And as a respiratory therapist, you take care of all the patients on life support systems and the respiratory and the pulmonary systems. And that in the U.S. military, that's approximately a 1-year school education. And I was in the military 3 years after that. So I did that successfully for about 10 years before I went on to medical school. But it's primarily caring for patients, especially respiratory diseases, caring for patients on life support, and ensuring they can breathe, managing the ventilators in the ICUs and in the emergency rooms. So every patient that comes in that's on a ventilator or needs life support system, the respiratory therapist is involved. And as you can tell these days, they are of vital importance. They are needed. They're on the front line. You know?
Yes. And I'm going to be asking you more about respiratory therapists on the ground in Trinidad and Tobago in a second. So you do that for 10 years, and then you realize, I want to do this, but I want to do even more. And so you decided to go to medical school. You went to Georgetown Medical School, which is a very competitive medical school. And along the way, you decided, I want to be a physiatrist. Now, for many people hearing that word, it might be the first time they're hearing it. What is a physiatrist exactly?
So I'm a physical medicine and rehab physician. So physiatry or a physiatrist is very unique in the Caribbean. There are about 4 of them in Barbados. I believe there's a few in Jamaica. I believe there's 1 in Grenada. But I was told I'm the only one in Trinidad and Tobago. I haven't met any others in Trinidad and Tobago.
Yeah, I am not aware of any either.
Yeah.
And I've been searching.
Physiatrists, we care for patients to bring them back, to allow patients to maximize patients' function after strokes, traumatic brain injuries, musculoskeletal injuries. But our goal is being the team leaders for all the rehabilitation services, physical therapy, occupational therapy, speech and language pathology, and on all the orthopedics, orthotics, and prosthetists in the world.
Yeah, and that's a pretty big deal, because for what we're about to talk about diabetes, stroke, in the Caribbean especially, and Dr. Kelly alluded to it last week as well. There are lots of people who have really poor outcomes because of their diabetes, amputations. They may need to have a prosthetic, like you're referring to. People have strokes. Prior to you coming to Trinidad and Tobago, I am not aware of anyone who had a dedicated center focused on patients in that way. If I'm not mistaken, Dr. Antione, patients actually had to go to Miami if they had the money and the resources to do that sort of thing, no?
Yes, that's correct. Presently, if you have good insurance or if you want to pay for yourself, I do send patients throughout the East Coast, Miami, Florida, New York, Washington, D.C., and also currently more recently I've been sending patients to Cuba. Right?
Wow.
But we're going to change that soon, right? Because listen, you do not need $15,000 US to get the ideal healthcare. That should not be. And I'm going to change that with my colleagues here in Trinidad. So soon, and I wish I had good news for you today to tell you that.
I'm hoping to hear it.
It may happen sooner than you think, but
good. Which is inpatient services.
Inpatient rehabilitation which is called an inpatient rehabilitation center, for which there aren't any in the English-speaking Caribbean. The closest thing to us right now is in Cuba, and it costs a pretty penny to get there.
Yes.
But we're trying to change that. We are trying to change that.
Why is inpatient rehab necessary?
Because the research has shown that when patients, there are approximately 126, the mortality rate for strokes in Trinidad and Tobago is 126 per 100,000. That's almost 200 strokes, 2,000 strokes per year.
In a population of 1.3 million, that's a lot.
It is a lot. And the research has shown almost 90% of patients who've had strokes, ischemic strokes, they do not come back or return to work if they do not have inpatient rehabilitation services.
Yes.
So based on my personal, anecdotal, research here in Trinidad, not necessarily scientific data. However, just evaluating the patients that I see, most patients will not return to work or return to being an active member of the community after they've had a stroke in Trinidad and Tobago.
Yeah.
And
so inpatient rehab is critical to resumption of quality of life.
Absolutely.
Mm-hmm.
The research has shown that when patients do have inpatient rehab, mortality rates decreases. That decreases the healthcare burden on the community, on the government. So it's important to have inpatient rehabilitation service. Currently, there isn't anyone. The normal transition, when a patient has a stroke, they go from the emergency room, they do 3 or 4 days in the hospital. 75% of those patients, if you're in America, Canada, England, somewhere, those patients would go to an inpatient rehabilitation service. And that doesn't happen in Trinidad and Tobago.
Because we don't have it.
That's right. Or the Caribbean, unless you have really good insurance or you can afford to go to Cuba.
And I have to say, I have a personal story to that effect, because last year I had my very close family member who suffered a stroke in Barbados. And through the network, we were able to get him help in Barbados, but ultimately we got him to you in Trinidad for his outpatient work, which is what I want to segue to right now. So while you're working to build your inpatient unit, you went ahead and started the Stroke and Diabetes Center back in 2016.
Yes.
Tell us about the center. What happens there, and who works there with you?
What's unique about, I needed to have a model in Trinidad and Tobago. It's like when you develop a community with 150 houses, you need to have the model.
Yes.
Because most people want to see the model house. When they walk up to your estate or the new community, where is the model house?
Yes.
And you put all the fittings and all the trimmings, and then you realize when someone looks at the model, they're like, I want this model. This is what I want. What Trinidad, when I came home, what we didn't have is, one, my specialty.
Yes.
Two, they have physical therapy. There is speech and language pathology. There is occupational therapy. But most times they're working individually. Mm-hmm. They're not working at the same place. What's unique about the Stroke and Diabetes Center is our patients are all under one roof. Mm-hmm. All our specialties, led by a physiatrist, a physical medicine myself, physical medicine rehab physician, and physical therapy, occupational therapy, speech and language pathology, nutritionist, an endocrinologist, a general practice physician, and we also have an OBGYN physician. We all practice under one roof, so the patient does not have to leave physical therapy, does not have to leave our building when they require speech therapy, occupational therapy. And more importantly, we can communicate amongst each other so we can know the direction of the patient's progress. This way is key in helping the patient return to become fully functional, because we're trying to maximize function here.
Yeah. So you're coordinating care, basically, which is it's physician taking care of patients. So you're knowing their blood sugars, you're knowing their blood pressures, you're managing that, you're communicating that with a speech and language professional. At the same time, on the same day when they're there for therapy, someone can assess to see how those things are progressing as well.
Exactly. So the physical therapist, the occupational therapist, or the speech and language pathologist does not have to tell the patient, go follow up with your doctor someplace else.
Yeah.
It's not just disjointed. We have a constant communication with the patient, with the family members, and we invite the family members to our facility. And what's unique about inpatient rehabilitation facilities is from the moment you wake up, you get physical therapy, you get speech pathology, you get occupational therapy, a minimum of 3 hours a day, 5 days a week. And in the first 90 days, rehabilitation care is so critical for spinal cord injuries, for traumatic brain injuries, especially for stroke patients, because that's when the brain is healing. After 6 months, the healing process in the brain is so slow that you barely see any significant changes. You may still have changes. I'm a believer, so a year later, you will still have minimal changes, but you do see changes. So the key is to get the patients in with the first week, right? In most institutions, now they get them in from the emergency room. Physical medicine rehab is involved from the emergency room until the patient is discharged 4 to 6 weeks later.
In countries like the USA.
Yes, absolutely. Yeah. And that's how the model is done in the States. And that's how it's done in most places. I haven't practiced in England, but I have colleagues, physiatrists in England, and I have colleagues in Canada. And and I've also trained with Chinese physicians who come to our institutions, and they do it the same way also.
It's true. And I have to say, again, speaking more from personal experience, I mean, I saw it as a medical student, I've seen it as a practicing physician, but speaking as someone who's a family member, I know that was critical to my cousin now actually being functional again, talking, moving, he's texting us and WhatsApping us and commenting on social media when we were initially told 24 hours after his stroke that he only had 24 hours to live. Yeah. And so it proved that early intervention was necessary and really important, particularly in patients. Now, my cousin, of course, really brought something home for me, which is this was someone who was quite young. He was under 50 when this happened.
You didn't know his name, did you?
Yeah, I know his name. You know him.
Because I know him, and I cared for him. And I saw him recently, and he's doing phenomenally well.
He's doing phenomenal. And again, as a family, we were having prayer vigils and mobilizing for how to travel because of what we were initially told about his prognosis. So it's so amazing to see where he is now and able to be back to caring for his family and experiencing life with his young family and his wife. But what it brought to my attention was, oh my goodness, diabetes, hypertension in the Caribbean is not only affecting older people, it's actually something that's affecting young functional people. Tell me more about that. What have you been seeing?
It's amazing. Now, practicing in the Caribbean, and I haven't done this. Remember, I left Trinidad as a teenager. I left Trinidad at age 14, going on 15, and I came home at age 54. And someday I'm going to put this book together. I've already started. I got a chapter, I think, but it's all in my head.
Yes.
It's called Welcome Home. My book will be called Welcome Home.
Yeah.
And I truly believe it's like, oh, I'm going home. I'm the only physiatrist in Trinidad and Tobago. I've already been to the mountain. I've been in the valley where people were rocketing me, and
you were in Afghanistan.
Yeah, I was in
combat. Yes.
So I'm like, I'm going home. Nobody's going to try to blow me up in Trinidad. But when I came home, and I truly believe we can do something special here.
Yeah.
The numbers are so devastating.
Mm-hmm.
I'll tell you, if you look at diabetes, the risk of having a stroke as a diabetic goes up 3 to 4 times.
Yeah.
If you're diabetic. Now, if your A1Cs are above 10, and I see this almost daily.
Almost daily.
Mm-hmm. Let me say what an A1C is, first of all. It's what I like to say is your average blood sugar over a 3-month period.
Yes.
Right. So, and your risk of having a stroke is 3 to 4 times the average person.
Yes.
Right. So when these patients have strokes, and I ask them, how long have you been a diabetic? and they're like 10 years. What is your A1C? And they what is that?
What is that? They've never heard of it.
And I am sure that doctors may have told them what it was. But you have to tell them over and over and over again. And the beautiful thing about it is, or what's troubling, I would say, about it is, they're intelligent enough. People are smart enough. They know they want to be helped. Patients want to be helped. And
they need information, though. And
absolutely.
That's part of why I do this, is because I happen to know that. I know that people from all backgrounds, all walks of life, the Caribbean, the diaspora, the United States, everywhere you look, genuinely I wouldn't say every patient, but the vast majority of patients that I meet genuinely want to learn. They genuinely want to know what's going on with their bodies. But it's incumbent upon us, the doctors, the mid-level providers, to present it in a way that they will understand. And to understand, like you just said, many times you need redundancy. It's not just one time. And you also don't dictate it to them. You find ways to communicate and express it. And I agree with you, having seen patients from Trinidad and Tobago as well. I'm quite amazed many times when I see the hemoglobin A1C. And at the same time, hear a patient say, but I was told my sugars are normal. Now, sometimes I wonder if that is a double-edged sword, because I've certainly read like the Pan American Health Organization goals, which is their goals are moderate sugar control. So whereas when I went to medical school, I was taught to shoot for tight sugar control. I know PAHO says moderate sugar control. Do you think that sort of wording leads to a translation that leads some to think that a goal of A1C of 10 is reasonable?
No, I think when they say tight in the United States, practicing in America, in Hawaii, in the military, in the Caribbean, versus practicing in the Caribbean, I like to, if a patient is a diabetic, and normal A1Cs is less than 6.3, and some people say less than 6. If my diabetic patient has been a diabetic for 7 years, 10 years, I'll take 7 any day.
Yes.
Anything lower than 7, I am a happy camper, and I'm giving them high fives.
Yeah.
I loosen up the reins when it's my a 50-year-old patient who's been on a diabetic for 10 years. So I do not try to get very tight control for my diabetic patients. And now that we do have an
endocrinologist for an A1C of 7.
Yes. So especially now we have an endocrinologist on board. So we try to coordinate our care so neatly and tightly that the patient doesn't feel like they're being left to do these things on their own. We do a lot of education. We do a lot of sitting down with the families, because when you tell patients don't eat sugar, don't eat dashing, don't eat, they're like, then I have to leave Trinidad. That's what I eat.
Right.
Remember, it's not only just Trinidad. I practice throughout the Caribbean. I've been to Barbados. I've been to Dominica. I've been to Grenada. I've been to Guyana multiple times. So this is not
too, right?
Barbados.
Yes.
Yeah. So it's not unique just to Trinidad. It's throughout the Caribbean. And the culture of it is we just need more education. We need more doctors like yourself doing what you do. And I appreciate what you do. So when you invited me, asked me to come on, I was like, oh yeah, absolutely. Especially the one in the doc. There are a lot of Caribbean doctors.
Yes.
Sprinkled all across this planet. And we don't need you to physically come home. We need you to do what you're doing. So especially these days where video conferencing is significant now, it's a part of our culture in providing healthcare. Right? You can actually see patients wherever you are in Vegas, and you can actually care for patients in Trinidad and Tobago. I also take care of stroke patients in Tobago, and I go there every Wednesday. It's a joy to me to do that. The medical team there are impressive, and it's usually never the medical team, are they doing something wrong? Are we doing something wrong? It's never that. It's how do we do it together?
Correct.
How do we get the patient at our level, or how do we get to the patient's level to educate the patient? because the patient, they're not into all of this medical jargon.
Yeah. Plus, it's, I like to tell people when you approach communities, particularly if it's a community that has been historically underserved for one reason or another, in this case, they haven't really used a physiatrist before. You can't just show up and say, okay, I'm a physiatrist, why aren't they coming, right? You do have to meet them where they are. You do have to teach them what you know and help them know what you know so that they can make decisions. And I like what you've just mentioned, because I think for a lot of people who are from the Caribbean and other parts of the world, they want to give back in their communities, but it's also not necessarily physically possible to travel to where they were from to do that. And so being in a situation like this where you can do more virtual, and we'll talk about that, because you've certainly been very instrumental in facilitating that virtual care for a lot of specialists, particularly in Trinidad and also in Barbados. But you've worked with not just people who are in your field. You've worked with me, that's for sure. You've worked with dermatologists, you've worked with hematologists, oncologists. And I think it's important that people know that there's such a conduit available as well to bring licensed, trained, and highly disciplined people to complement those who are already on ground in the countries doing amazing work. Amazing work.
You remember, I like to put these things in military terms.
Yeah.
The doctors and the physicians, the nurses, the frontline staff, the nurses who are in the community centers, they've been here doing works for hundreds of people, doing their work. And they're not getting it. I like to think the primary care doctors is the tip of the spear. They're the warriors. They're doing all the work. And the guys, we're the guys way in the back, right? So we hardly ever get any incoming. But the guys, they're in the battle every day and they're seeing it. We're here to complement them. So when I show up as a physiatrist and a general practitioner who's trained in the Caribbean, and there hasn't been a physical medicine rehab trained physician, residency trained physician, there have been people doing what I'm supposed to, my specialty, but they aren't resident, they may not have been residency trained. So when I show up and says, oh, I'm a physiatrist, or I also bring an endocrinologist to Tobago every Wednesday. Mm-hmm. So when we show up as specialists, they're like, wait a second, we've been doing what you guys have been doing for 30 years.
Yeah.
We have to humble ourselves. We're not here to take anything from you. We're here to complement you.
Yeah.
Our goal is to serve and help. And I think I've done that since I was 17. We're walking around in the woods with a bunch of infantry guys. That was fun. But here we're serving in a different capacity, and I truly enjoy it. And I am truly honored to be home. And when I go to Tobago on Wednesdays, or when I go to the hospital here, or when I see patients in my office, I am humbled by providing care, because we have done this in foreign countries, in countries that we've lived in, and they're Trini doctors, Jamaican doctors, and there are doctors doing this all over the world. What we ask of you is just to come home for a weekend, do some teleconferencing, and we can save a few lives. And that's just
more than a few lives, to be honest. I remember our health fair, let me think back to 2014, when we brought, and just to let people know, you can even turn it into a vacation style event once COVID is passed. Yeah. At the time, it was me, my mom, my brother. We all came home, and my mom was there helping with blood pressure. My brother was walking around taking histories and coordinating, getting people to the line for blood pressure, to the line for blood sugars. And I remember when we did it in Tobago, for example, in 2014, that day we screened over 300 people. Yeah. And actually helped quite a few people get a number of different subspecialists, basically doing mini consultations right then and there in that tent.
Yeah, Cindy, the funny thing is, since you mentioned your brother, right? I remember you made it a family event because you guys traveled together. And
we did.
A lot of families do that. There's a family that comes, Dr. Ashing, I don't know if you remember her.
Yes, I remember Kimlin from California.
From California. So there are hundreds of doctors that come from all over the world to serve with us throughout the Caribbean. And when I met your family for the first time, and I met your brother, and he says, "Oh yeah, I'm an actor and I'm doing this movie called Black Panther." I was like, "Good luck with that movie." So it's the little things that we do that keeps us connected. Now, 6-7 years later, I'm back home. You're in Vegas. You're finished with fellowship, right? And we're continuing to serve. And I honor your service. We may not be on the front lines. I don't think I'm on the front lines anymore. But when I see patients in the hospital or Tobago, I carry myself like I have COVID, and I'm trying to protect my patients from COVID-19. Yeah. So I protect me from giving my patients anything.
Yeah.
Right. So I am gowned up, I'm masked up, and I take care of my patients that way. But as far in reference to COVID-19 and the devastation it's wreaking havoc all over the world.
Yes.
I think in Trinidad and Tobago, I can speak for that.
Yeah.
I've been back to the States since. The people are supportive. The citizens are doing what they're supposed to do. The healthcare system is doing what they're supposed to do, and I am grateful and honored to be here today, to be in the spot that I'm in, because I know if I was in the States, I'd be working. I did get a call an email from the U.S. Army Reserve and the Veterans Administration, but I've chosen to be
trying to recruit you to fly back home.
I have chosen to be here because I have done my 31 years and more. I'm done.
Yes. And it's true. Credit to Trinidad and Tobago and a lot of the Caribbean islands, all of them really. They've been working very hard, and the communities have also taken individual responsibility. I certainly think as a virologist, I'd love to see more testing done. But until then, I'm at least heartened by the fact that the numbers are flattened. Certainly in Trinidad and Tobago, we haven't heard of any reported deaths in well over a week, which is amazing news. Jamaica, the deaths have also stayed stable. Now their case numbers jumped, but they also quickly indexed and located the source of that outbreak, and quickly, it seems, have gotten it under control. But you mentioned a really good point there, which is COVID-19, and certainly what we're seeing right now, which is we're starting to enter that recovery phase, right? Even in Trinidad and Tobago, we're hearing of the recovery phase. We know 114 people have been confirmed infected. They have over 18 people recovered. But what we're also learning is recovery doesn't mean they're now fully functional. And so I'm glad to hear you say that you're taking precautions as you take care of those who are recovering. In terms of advice for the population and people who are at risk, because if we're also being honest, we know now that patients with diabetes, high blood pressure, lung disease, smokers are at increased risk for having COVID and complications. I know for a fact that once people start getting up and about again, the risk of infection will rise again, a transmission. What can someone who's sitting at home watching us right now, who has diabetes, has blood pressure issues, or history of a stroke, do to help reduce their risk in Trinidad and Tobago and the rest of the Caribbean once we start getting the economies going and people back up and moving?
That's a good question. The key here is patients who are at higher risk. In my patients, the diabetics, patients with hypertension, cardiovascular diseases, the post-stroke patients, they're a little more susceptible to worse outcomes if they contract the disease.
Mm-hmm.
Right? However, they must do exactly what everyone else in the community is doing. Protect yourself. Wear a mask if you're going to go outside. If you're going to come to the office, most times, I recommend that they wear a mask in the office. If you're going to be with family members, even if you're unsure of the family members' whereabouts, wear a mask. Social distancing, 6 feet. These are the guidance given by most governments. And if you adhere to these guidance, I would say you're going to do well.
Yeah.
And you're just because you have diabetes, not doesn't mean, or if you have had a stroke, doesn't mean you're going to walk outside and poof, you're going to get COVID-19.
Right.
That is not the case. And some patients have asked me, am I more likely to catch the disease? No, that isn't the case. What it is the case is, if you do get the disease, you are more likely to have worse outcomes than patients who do not. So that's basically what it is. Mm-hmm. And I try to educate all my patients on that, is follow the guidance that's put out by your local communities on a daily basis.
Are you offering telemedicine services? I've certainly had a number of people reach out to me asking, how can I get my diabetes checked? How can I get my blood sugar checked? How do I know what my A1C is? Since Dr. Kelly was on last Sunday, I've had a lot of messages, emails, questions asking, how, Dr. Duke, how do I get this done? Mention that you're in Tobago, you're in Trinidad, which means in Trinidad and Tobago, you have locations on both islands.
Yes.
Is there a process for seeing Dr. Antione? And is it only for patients who know they have diabetes or stroke, as the center's name says?
No, we see all patients. We do have an OBGYN physician here also, but we do I think your question was, do we offer telehealth and telemedicine services?
Yes.
And the answer is yes, we do. We have a electronic medical record platform that offers that directly. So we can provide physical therapy via that service. We can provide occupational therapy, the things that's hands-on that you may have to come in for. Or we also provide speech and language pathology. I was recently approached last week by an insurance company. I don't think I can say the name.
Right.
But they wanted us to be one of their premier sites for doing the telehealth and telemedicine service for one of the leading insurance groups on the island. It's right. And of course, I would say yes. But so yeah, we do offer telehealth and telemedicine services, and everyone has a cell phone in Trinidad and Tobago.
Yeah. And most people have smartphones. They're mostly all on WhatsApp and Facebook.
Yeah, and almost every cell phone has a camera, so it's relatively simple. And it's just, once I send you the link, you just click on the link, and we can, and we've done it a couple of times already, and we've always had that service.
Right.
But these are cultural things that we need to overcome, because people want to actually do FaceTime with their physicians. Yeah. And not every case needs FaceTime.
And I think that's important to say here, because as someone who also does telemedicine there via video, I would say yes, the willingness and the ease with which it's done is actually way less complicated than most people would assume. I especially want people to hear this, because that means, for example, somebody who's right now in Charlottesville and maybe has a question about diabetes, stroke, a family member maybe had a stroke, they could have some interaction and visits with you via phone.
Oh, absolutely. So we can anywhere on planet Earth. Let me be clear. Let me give you an example. I'm on a little mountaintop in Afghanistan. I have a little X-ray machine, right? And so if a young soldier fractures his ankle or fractures the leg, I need to make sure that leg isn't broken.
Yeah.
Before I send them away, call a helicopter to come evacuate them, and risk 6 other people's lives on a helicopter.
Yeah.
To come pick up one young man. I take an X-ray, I send it to some guy on a ship, some doctor on a ship. He emails me back 20 minutes later, says, oh, the ankle isn't broken, it just looks really bad. I keep him on a little, what we call a combat outpost, keep him there for a few weeks, versus calling, even, sprained ankles,
right?
Very impressive and bad.
They swell very quickly. Yeah.
Ooh, look at that. So we have done this X-rays over, and even from Desert Storm, and I'm from a Desert Storm veteran also.
Yes.
How long ago was Desert Storm?
1990.
Yeah, 20 years. 30 years ago.
30 years. Yeah.
Are you sure? Is it that long?
It's between 90 and 94. I mean, Bush was voted out in 1994.
Yeah. So even way back then, those That's when we started developing.
Bush was voted out in 92. So yeah, it was 1990.
So these capabilities have been there for 30 years already. So it's not new. But we get to deploy today.
It's also very clear that your history in the military is a tremendous resource. Just that alone is a resource that really speaks volumes for what you're doing today.
Well, this is my piece. You know, this is my this is being in Trinidad and Tobago caring for patients is my my moment in life, because I've been there, done that. I've been scared enough to know what joy is. I like my joy.
Yeah. Now we have a lot of comments, so we'll go through our questions and also get through the comments so that everybody can get to ask Dr. Gerard all their questions. So we have some, Coco is saying boom, you know Coco. Laura Diane Jerry says, good afternoon, Dr. Duke. Monica, hey Monica. Monica is the program administrator at Yale University, where I did my fellowship. Hi, Monica.
Hey, Monica.
Hi. Laura says, good afternoon, Dr. Antoine.
See?
Joan Phillips-Pierre, a familiar face. Joan is also a nurse.
Joan, we miss you. Sorry about that last year, but we miss you.
Joan works with us in Caribbean medical providers practicing abroad. Coco says, ask the doctors anything. All right. Ingrid, you know Ingrid?
Absolutely. Ingrid is a true warrior.
Yes, Ingrid is also from the CMPPA crew. Beaches seem to also help in recovery. I have seen stroke patients. So this is someone's mentioning that the Caribbean beaches, they've seen stroke patients. Certainly I've seen the groups in Tobago on the beaches keeping fit, or what we call exercise. Now that's actually an advanced stage of stroke recovery. No, is still necessary first to really help that stage.
Absolutely. If you're activity, the key here is activity, right? So if you're able to walk, get in the water, I would recommend that you get in the water into beaches. The challenge is the waves. If you can do aqua therapy, where you have someone in the pool, and where someone, an instructor helps you with a physical therapy type activities, even better. But the ocean is great. Remember, for the last 14 years, I've been in Hawaii.
Yeah.
Hawaiians believe the beaches are their thing. That's their God. Right?
Yeah.
So post-stroke patients will get in the water. The salt water is good for you. If you can get into the water, absolutely, I would recommend it. Do it.
Yeah. But make sure you're safe, meaning make sure you can walk, make sure you can swim, make sure the beach is safe. You have a lifeguard and other services. And better yet, don't get in the ocean at first. You should be doing this initial work in a pool.
Yes, initially. So because remember, most times if you have any form of disability, it may be challenging for you to stand, it may be challenging for you to swim. And if you get knocked down in the water, it may not be easy for you to stand.
Correct.
So the key here is safety. Make sure you have someone with you. Don't go by yourself.
So really offsite, the answer here, what we're saying is we love that, but we think more is needed. At least this is what Cindy Duke is saying. I think more is needed. It's good to have the beaches, but the beaches aren't always safe. There are currents, tide, fish. There are a host of other issues with the ocean. So while it's a lovely resource to have, we can't console ourselves with simply saying we're surrounded by salt water. We need facilities on land that can help with these services. And
there are a few places here that provide pool therapy for our stroke patients, and they're doing a good job at it.
Yes. Cora Panton, my mom is saying, call his name. He would be proud. Yes, so that's my cousin. His name is Brent Powder. And we are just so proud of Brent, so happy for Brent. TJ says, yes, repetitiveness is important in getting the point across. Indeed. Indeed. And I think that's a lot of what, I'm hoping that these videos and these interviews and bringing guests back multiple times to talk about related things helps with, is getting people to understand that repetitiveness is not us shouting at you, it's not because we don't think you're listening, but it's because we're all so busy in life. You need to hear some things more than once. And when it comes to diabetes, hemoglobin A1C. If you've never heard the term hemoglobin A1C, now's the time to get in touch with your doctor and say, hey, how do we talk about this? What is this thing? And how do I get it checked? Because even if someone doesn't know they're diabetic, when would you start screening someone with hemoglobin A1C?
So let me give you an example. I have been in the military I joined the United States Army at age 17 in 1980.
Yeah.
After age 40, they checked my A1C every year. I'm not a diabetic. They check my PSA every year on my birth month.
Which is your prostate-specific antigen. And that's another issue that we see a lot in the Caribbean, which is high rates of prostate cancer with delayed diagnosis.
Every year.
Yeah.
And I do not have benign prostatic hypertrophy. I don't have prostate cancer. I'm not a diabetic, but you do it every year. And I tell patients, if you're on your birth month, once a year, you schedule all these things, including your pap smear, if you're a young woman, including if you're over 40 based or over 45 or your family history, including your mammograms. You schedule it like in the military around your birth month, so you can find all these things in one group. You go once a year. Hey, doctor, how you doing here? I would like A, B, C, D done, and get it over with, right? But
and that's important because you grew up in the Caribbean. I grew up in the Caribbean. Yes, I now live in the United States in Las Vegas and all that jazz, but we grew up in a culture where most of our medical interest as a patient was when you had something acute happening, right? Yes. I need an infection treated. I need antibiotics. I remember as a kid growing up, many times antibiotics because my mom went to the pharmacist. We didn't even need to see the doctor. And so I know culturally it's not something you necessarily are used to doing, but it's important that we review that. So you're saying use your birthday as your health anniversary every year.
Absolutely. And speaking of cultural, let's go over some cultural things.
Yeah.
I haven't heard of this before until I got home. I was told that when patients have strokes, they should put a nutmeg in their mouth.
Nutmeg or a spoonful of salt.
Yes, but we laugh at these things, but there's some truth to some of it, right?
Yeah.
So nutmeg has some medicinal purposes, and naturopaths have used it for years, right? To treat high blood pressure, to treat cancers. But the medicinal purpose of nutmeg, I think it's a vasodilator, and it can also cause, and it can be used in stroke rehabilitation. There have been some research done on it where it is positive. So when patients tell me my concern is if you're having a stroke and you're having problems with swallowing and speech, will it be safe to put a nutmeg in your mouth? That's my biggest concern.
You might choke the person. Yeah.
Exactly. So yes, there are some benefits to nutmeg, and I think you may have to, nutmeg has a hard shell over it.
It does.
So I think you have to take the shell off to get the benefits of the nutmeg.
And it's true because culture has a lot of meaning and context in the Caribbean, all over the world, but especially in communities of color. And in the Caribbean, of course, there are very large communities of color, whether they be people of African heritage, East Indian heritage, Asian, otherwise, so Chinese, Southeast Asian heritage, people from the Middle East, Lebanese, Syrian. So there's a lot of cultural infusion and a lot of cultural practices that inform most people's reactions to things. And it can lead to some myths. So I'm glad you brought the nutmeg one up, and why, although it has medicinal benefits in an acute stroke setting, you still need to see your doctor first.
Absolutely. So
what else do you see?
So let's talk, first of all, let's talk symptoms, okay? We use the acronym FACE. If you have facial weakness, arm weakness, speech weakness, FAST, facial weakness, arm weakness, speech changes, and time to call the doctor, right? Mm-hmm. So you need to get to the doctor. If you're having symptoms that resembles a stroke, a face, arm, speech changes, do not take an aspirin, because truly we do not know what type. Yeah, there you go. I see. We do not know what type of stroke you're having, because there are different types of strokes. So if you take an aspirin and it's a hemorrhagic stroke, you will bleed to death, and we don't want that. The key is to, if you recognize that you think you're having a stroke, it's better to get to the hospital immediately, versus trying to put a nutmeg in your mouth or taking an aspirin. The goal is to get to the emergency room or your doctor's office as soon as possible.
So if you think you're having, let's review FAST again, because we're learning today. We're in class.
Yes.
So signs of a stroke, we're going to use the FAST acronym, just like we learned the Stop Bang acronym on Friday for sleep apnea. So FAST. So if you're looking at your family member, you're looking for one of these things. What is it?
Facial weakness, like your face drooping, facial drooping. Right? Yeah, well, let's do it the locally.
Yes.
Your face twisted up.
Yes, if your face twisting up.
If your face twisted up. Arm weakness or leg weakness. Speech, if you're unable to speak clearly, or if your speech is different.
It's not making sense. If the person suddenly stopped making sense.
And the T is time to get to the hospital.
Yeah.
Time to get to the emergency room. Have someone take you immediately.
Because the theory is time is brain. Right?
Absolutely. We need to get you there fast. Okay?
Mm-hmm. Now, once they get to the hospital, speaking on it in however you might be able to speak to it, I don't know how detailed you can get. How good are the systems right now at recognizing stroke using the FAST acronym protocol and implementing, taking action? What have you seen?
Not everywhere throughout the Caribbean has the medications to treat acute strokes in the emergency department. What we call
TPA,
the tissue connection activators. It's a specific medication that we inject to break up the clots if that's the type of stroke.
Yeah.
Not everywhere, not every institution has that throughout the Caribbean, and that's a challenge, and hopefully we'll get there one day. And all
of the challenges, I have people, the nice thing about this program is there are people who are listening who have the resources, who work with pharmaceutical companies, who work with drug companies, work with different nonprofits, myself included. What is the reason why TPA, tissue plasminogen activator, is not readily available? And of course, I'm speaking about this also as someone who explored this with my cousin last year. Why is it not available?
Number one thing here throughout the Caribbean is cost, right? Remember, not everyone who shows up in the emergency room will get TPA, the tissue plasminogen activator.
Time is a factor. 3 hours?
But so we have 3.5 hours to 4 hours, right? And we can also do some mechanical thrombectomies also. And that's a 24, it's a surgical procedure where we can insert a line so we can extract the clot from the blood vessel. Mm-hmm. So, and that's a 24-hour period. But not every institution we may not have the physicians who can do those procedures. No. So we're trained to do this procedure. Just like in the States, you may not have that if you end up in, I don't want to call any
rural area. If you're somewhere rural,
rural place, you may not get TPA, you may not get, mechanical thrombectomies. So they have the same challenges, but the primary reason is cost. It costs almost $40,000 TT dollars.
Wow. So 40,000 TT, we're talking somewhere at a $6,000
US dollars.
Yeah, it's about 6,500 US. So that's for one course of TPA?
Yes, it's roughly, yes.
Okay, that's expensive.
It is expensive.
Why is it so expensive?
Well, I need to speak to someone in Big Pharma, right? Yeah. I wish I could control that, but currently I can't. And I truly don't know why it's that expensive, but it is expensive.
And then other than the price of that, what else can they use? So TPA is one, we have a limit in that. How about imaging? Because as I recall,
imaging we can do. I mean, if you look at the process, from the moment the patient lands in the emergency room, they have the same process like any institution I've seen. Good. Yes, especially now where no one's in the emergency room, right? And there are patients there have been small studies, Dr. Cindy, that have shown that patients who contract COVID-19, their increased episode risk of strokes and
yes, we're seeing more and more papers showing that and other neurological deficits.
Yeah, so there are small studies, but not anything massive, and we'll get to that at some point after this is all done.
Yeah.
But the key here is, what is the normal process as we move patients through the system from the moment they land in the emergency room to a point of discharge on the other side? CT scans, NG tubes, medications, speech therapy, occupational therapy. Unfortunately, there aren't a lot of occupational therapists or speech and language pathologists in the public systems. And so that's a challenge, and there are institutions working on that. But I think the process is just as good. But remember, we're here in systems that may not have all the resources readily available. But based upon
and it's so interesting because I have questions I want to ask you, but I have to walk a fine line because I don't want to ask you questions that put you in hot water later, because we know how the Caribbean and other diaspora communities can get. So I understand what you're saying, and hopefully some of our audience can read between the lines. But that is very interesting when you refer to a public versus non-public health system, because I think many people around the world assume that if we say there's what we call socialized healthcare, everyone gets the same care. But you're actually suggesting that there are two levels.
Well, what I think is, just like in the United States, you can get everything you want, but you must pay for it.
Yeah.
So we may not have all those that system in place in the public systems, but it's available. It's not, you can have any healthcare in the Caribbean could be just as great as in the United States. You can get, any type of heart surgery in most places.
You get TPA?
I'm sorry?
You can get TPA if you have the money?
Absolutely. If it costs. And just like, there's a cost associated with it. And just like you can get IVF in the Caribbean. I don't know if they offer,
touche.
offer IVF in the public system in the States. Do they?
They do. There are states that it's now considered mandated states. So there are now 14 states in the United States who have mandated IVF as part of their requirements for health. And so like New York State is the most recent one. So as of January, New York has joined Massachusetts, Illinois, etc., where yes, insurance companies
they will pay
for Medicaid. They will pay for services. Yes. Even here in Nevada, there are many public insurances, like the one insurance company, the largest insurer here in Nevada, which insures 60% of the lives in Las Vegas, actually provides fertility services, but not IVF. But they do provide insemination and so forth.
Okay.
Wow.
Yeah,
I have more questions for you.
Yeah, but we can. There are ways that we can improve on what we're doing. There are always opportunities to improve what we're doing.
I think you just answered this question. It's just Ingrid is asking, how would COVID-19 affect the likelihood of having a stroke? And you were just saying that there's emerging data that shows patients with COVID at increased risk for strokes.
Yes, so they're seeing that primarily in the ICU. They're in the little small study that I read recently that they did see, and they're still trying to figure out why that is. Remember, what's happening right now is very dynamic.
Right.
There are a lot of studies out there that's ongoing, and there are a lot of things about COVID-19 that we do not know. And just because I say it today doesn't mean it's going to change. Tomorrow it may be different.
It might be different. But I think that one is holding because they're seeing more and more cases and a larger number of case series. The New England Journal of Medicine just put out one talking mostly about just the neurological differences they're seeing in the ICU and the ischemic damage that's happening. Sharon says, good evening. Belmel says, good evening. Patsy says, good evening. Thanks for all you're doing. I'm trying to get to the questions. Joan says, giving back your services to our country, Dr. Antoine. The patients I have referred are happy with your consultation and care. Thank you so much.
Thank you, Joan. And Joan has been a phenomenal supporter of what we're trying to do here in the Caribbean, and her family. God bless you. We are truly grateful for your support. So since we're talking about cultural issues, right? Here in the Caribbean, and I've seen it around the Caribbean, including Guyana, they do a lot of B12 injections after strokes for treatment. Yeah. So, and in that too, there have been some studies that show, and there have been long studies. There was I forgot the name of this study, about a 12-year study. I think it's called a Vita Top study, or I don't know if you've ever seen it.
No, not that one.
Yeah, there's a 12-year study where they took the different B vitamins and used it to treat patients before and after strokes. And, after 12 years, they're like, it's really can't tell.
Right. So no difference, no statistical difference in outcome.
But there have been positive results with patients. And again, these things are somewhat anecdotal, observational.
Right.
But the key here is that if you treat patients immediately after strokes with high dose B12 injections, is it really the vitamin B12 that's causing positive responses or positive outcomes, or is it the patient's,
immune system and their repair process?
So sometimes, the brain is very what we call neuroplastic.
Correct. Yeah.
It heals on its. If we did absolutely nothing, if Dr. Antoine went away and all the neurologists went away, will those patients recover on their own?
No, we've seen that. I grew up there.
Most times,
they have some recovery, but not the level that they want.
That may not be 100, but most times within the first couple of weeks, patients get significant improvement. Even if we did absolutely nothing.
Right.
So what we call the neuroplasticity of the brain.
Yeah.
We are grateful for that, and what the good Lord made that happen. I think
neuroplasticity and what we're learning, what seems to be neuroredundancy, which is different parts of the brain can literally step in and help out other parts. Dr. Wolcott, who is an orthopedic specialist who also travels, she works in the United States, has done some amazing work here, but also I'm pretty sure travels through the Caribbean and does some work as well. She says great info.
Oh, great. Thanks, Dr. Wolcott.
Yes. Patsy says it's really a privilege and an opportunity to give back to our country. It's been my desire to give back. Well, Patsy, this is the man to talk to. He can help facilitate that. I can facilitate as well because I learned from Dr. Antoine, but he's the man on the ground. Winston Toussaint says, I was sleeping, just woke up. Thanks for the invitation. Winston is from Trinidad, but lives in Canada. I'm starting to learn my audience. I'm learning who my audience is as they reach out. Listra says, what's on? Omar says, thank you for your military service. Yes.
You know what? I'm not taking advantage of my all my military retirement perks. So, like the tax-free shopping at the PX. But it's way better, picking Julie mango trees off in your backyard. So life is
very good. Yes. Winston says, I guess I missed quite a lot, but we'll listen to the rest to try and catch on. Patsy says, I must say that we came from a very rich heritage, and our early beginning is what shaped us into who we are today. I applaud both of you doctors for who you are and what you are both doing. God bless you richly. I'm praying for you all. Prayer's always good. We'll take it.
I wasn't able to say things, prayer and the Lord and Jesus, when I saw a lot of my patients in the military. I can do that now, right? I do it a lot now. But, truly, I want to give, if you don't mind me doing this, there are nurses and young doctors out there who are every day are putting themselves on the line and caring for patients. Mm-hmm. And we were young doctors once, and we've been there, done that. And
I still am young. Hello.
I employ. We're still seeing patients clinically. We see patients every day, and we go. And in my case, I have gone places that I rather would not have gone, and I have had things that I wish I could have said no. But so I applaud these doctors that I see on a daily basis, the nurses, the primary care physicians that we see on a daily basis doing what they do. Truly, my heart goes out to you, and thank you for your service.
Indeed. Healthcare workers, they're picking up every day, going in. Many are going in not even sure if they'll have PPE for that shift.
Yeah.
Not sure in the door. And then in terms of our nurses, it's got to be hard, that repeated trauma of watching patients die, doctor, nurse, respiratory therapists, all allied staff. Yes, indeed. We really need like a moment of silence for them, to be honest.
You know, and I get that, because as a former respiratory therapist, I have spoken to some of the leadership here about getting respiratory therapists involved in the country and developing programs as respiratory therapists in Trinidad and Tobago and throughout the Caribbean, because a lot of the Caribbean, because remember, if the respiratory therapist is managing the mechanical ventilation or the mechanical ventilators in the institutions, there are no other ventilators going on a daily basis. They may not be in need, but there comes a time, and there are other things that they do, and other than just the mechanical ventilation, there are a lot of other things that I probably can't even go into right now. There's so many other things. But
speaking of that, how many respiratory therapists are, if you were to estimate, how many are in Trinidad and Tobago?
I believe, let me say it this way. First of all, I may not be privy to that information, but based on my understanding of the healthcare system now, I do not believe there may be that many, if any.
Yeah.
So I truly, if I had to take a wild guess.
Right. I'll be honest, that's stuff that should be known. I don't think that needs to be secret. I think it needs to be known, because we certainly have a lot of respiratory therapists who are in other countries. They're all working now, but there are also a lot of them who are retired, who can train other people as well. There are resources. And, I know this was how I felt, especially while I was there working with CMPPA, is we can't help things if we don't know what needs to be helped. And that's where a little bit more transparency in numbers. I'm going to speak, and I'm speaking for Cindy Duke, not Dr. Antoine. That's information that's helpful. That's helpful information to have. We can't help you I can't help you if I don't know what needs helped. And in order to know, we need the numbers. We need to know how many respiratory therapists, how many ventilators. There are places now mobilizing to send ventilators to countries in Africa, since we've discovered that there are 14 countries in Africa that do not have ventilators. I've been talking with some tech companies that actually are working to make ventilators using 3D printing. But again, people can't really help. There are people who want to help and have resources to mobilize help, but they cannot help if resources aren't available. Yeah. Cora says the live is frozen. Is it still frozen, guys? Can you give me a thumbs up if it's not frozen? I would think it's not, because I see questions. So let's go through our questions for you. Why are doctors telling you to wash your hands every minute, even though you are inside your house? I believe when you go to the toilet, why can't I read this? You got to wash it, but not everything you touch, even touching your face once you're inside your hands. Well, Winston, the reason is because actually there's the whole principle of viral shedding and what we call fomites, which are surfaces where viruses then collect. And while mist and breathing is a primary source of contracting, if you touch your face and you are breathing, particles are on your face if you touch different things. So yes, we say wash your hands, also clean the surfaces. So it's not just washing your hands, but actually cleaning these surfaces with disinfectants, whether it be a 10% bleach or something like Lysol. But you do need to beware. It's not poppycock. It has meaning, and it's necessary.
That's an awesome answer, Dr.
Yeah.
That truly is an awesome answer.
Thank you. I try. Joan says, good seeing you. Thank you for your services, especially your Wednesdays in Tobago. When did you start going to Tobago, Dr. Antoine?
I started in December 2018. December
And
2018, yes.
are you able to share in broad terms some of your successes in Tobago? Obviously, Tobago holds a special place in my heart, being my home island. It's a country of 1.3 million, but Tobago is 6,000. It was about 30,000 when I was growing up in terms of population. And so whenever someone is injured or hurt there or has a stroke, it feels like your family member because the whole island feels like family. Yeah. What have you seen? What are some of the successes you can share with us?
I'll tell you, Tobago also holds a special place in my heart because now that I go there once a week, and now with the flights, the once-a-day flights at Tobago, I struggle to get flights there, but I do. And it takes a lot of planning and coordination. What are some of my successes in Tobago? What's good is we get to have a team, including an endocrinologist, that we can guide the care, and especially with the speech pathologist, the occupational therapist, and the physical therapist. Now I get in the past, there are those services, but it's not
coordinated
with a physician. For example, when a patient comes in, previously to us showing up, us starting, when a patient comes in and their blood pressure's horrifically high or their sugars are horrifically high, that patient would be instructed to either do two things: go to your doctor, go to the emergency room, and most times, because the patient knows a challenge, they would go home.
Yeah.
Now we can address it immediately. Right? So there's no longer that need to send the patient away so they can, because most times you're not going to walk the patient to anywhere and they'd have to do an appointment. We can address it immediately, right? So the endocrinologist is on the team, I am on the physiatrist is on the team, and the therapist can come directly to us so we can address the problem. That saves lives.
How do you find your patients in Tobago? How do they find you?
Well, it's a private-private partnership. So when patients have strokes in the public system, they are referred to us at the Stroke and Diabetes Center, which is an off-site.
Where are you located, if you don't mind me asking? Because if we're being honest, Tobago has one hospital. So if they had a stroke, the single hospital is charged with sending them to you. Although it's a public-private partnership, there's only one hospital, a public hospital.
So when the patient is discharged, and the length of stay usually is about 3 to 4 days, and there have been two good, decent research studies that were done throughout Trinidad and Tobago most recently about 10 years ago. So most hospital stays are about 4 days. On the 5th day, they would be discharged, or the 4th day, they'd be discharged. And we're located at the
are they discharged to their house?
They're discharged to home. Discharged to home. So we're located at Fort George. Fort
King George? Fort King George.
Fort King George on the hill. Yeah. There's a separate building there at the Stroke and Diabetes Center. It's located.
The old hospital.
The old hospital.
Yes.
Exactly where the old hospital. And that building used to be a building for residents or for doctors. So it's a building that they outfitted for us that we can see patients. The key here is when they were doing this process is to decentralize the healthcare. Instead of having patients go back into the hospital once they've been discharged, they would go to a separate institution. And now it's coming through that patients may not want to go to the hospital because people are afraid.
Of COVID.
COVID, not that there's nothing wrong with going to the hospital. I would go to the hospital. And
Me too. Yeah.
But patients, they're somewhat nervous about going to the hospital, but they're not nervous about coming to a separate building outside of the hospital for care. So last week when I was there, we saw a lot of patients. And it's always been like that. We've seen a lot of patients. We saw almost 1,000 patients in 2019. So,
that's a lot.
Yeah, we've been doing some more, and I think it's worth it to provide care in this way.
So if someone's listening right now, and so they're not either them or their family member neither are in the hospital, but they'd like to come see you. They've either had stroke, they have diabetes, they have high blood pressure, and they're from Tobago. How do they see you?
So I don't have the number sitting in front of me, but you can. I'll send it to you, and you can publish it at any time.
Yeah. Okay.
But you can probably put it on your Facebook page.
We will.
But the key is they can always call my office number and tell them which is 225-4120, and tell them they're in Tobago and they like to be seen in Tobago. So the referral process is such that once a patient is discharged, the primary care physicians in the hospital, the inpatient physicians, the hospitalists or the general practice doctors will refer the patient to the Stroke and Diabetes Center for care for myself, physical therapy, occupational therapy of speech. And also, if you're a diabetic and you need to be seen by an endocrinologist, I do not believe there's an endocrinologist, a resident endocrinologist in Tobago. So we do bring an endocrinologist with us, and she provides care there. Yes, can the general practitioners do exactly what the endocrinologist is doing? Absolutely, but it adds an added dimension. And
plus a general practitioner is busy. The endocrinologist can help them with their burnout. There aren't that many doctors, being honest, in Tobago. And so to take care of a population of 60,000, if you have an endocrinologist who can focus on your diabetics for you, you can focus on doing other things. It's not a competition. It's a complement and a supplement.
Yeah, so that's what I remember. I have to educate the physicians about who I am.
Right.
I said, I'm a physiatrist. And they're like, so does that mean you're a doctor? I was like, yeah, I think so. So right. in my world, I also have to educate my colleagues on what and not everyone in my book is somewhat welcome home, right?
Yeah.
Welcome home.
I do think that's something that we need to work on in general, that receptivity. And hopefully a talk like this today helps them understand that you're not new to this, you're true to this, and you've always been pro-physician. You support the medical community, you support doctors, you support nurses, you support physical therapists. Yours was the first conference that I'd ever been to before I was helping to organize. I came as just someone attending the conference. And not only did you have doctors there giving talks, you had nurses giving talks, you had physical therapists giving talks, you had speech and language pathologists giving talks, you had physical therapists and occupational therapists, as well as pelvic physical therapists. It was phenomenal, as well as epidemiologists. You truly organize a very integrated and broad-reaching conference.
So we normally talk to ourselves. When I go to when they go to conferences, they speak to each other.
Yeah.
Other cardiologists. What we're trying to do, especially with strokes, it's a team effort to decrease. If you look at the per country morbidity, Trinidad and Tobago lands at number 3.
Wow.
For morbidity on planet Earth per 100,000.
For stroke morbidity per 1,000.
Diabetes. And with diabetes, the risk of 3 to 4 times higher with strokes. So when you compound it and you compile it, it's all integrated. I need the help of the general physician. I need the help of the physical therapist and the speech and language pathologist. I need the help of the endocrinologist in order to keep my patients, who now is my mother, my sister, your cousin, your family member. It's my family. Now, I practiced in the United States for 20-something years. Even as a combat medic, I never saw it as my family. I saw it as a job, and I did a job, and I enjoyed doing my job. I am 5 miles away from where I grew up. 6 miles away. This is home. The people that walk through my door knows this one patient. She's like, Antoine, let me see. There's no mother. And I'm like, oh, this is crazy.
Yes. And that's very much the Caribbean, especially Trinidad and Tobago. I mean, like, I joke with people, but, if we hear certain names and they say they're from Tobago, and my mom immediately does her genealogy and she's like, last name so-and-so, they're going to be related to this person, that person, call them. If the person can't verify, it's almost as if they just failed a background check, right?
It's crazy, but here's what I instruct patients. When you get discharged from the hospital and you're going to come see us, bring all your paperwork with you.
Yes.
Right? I need to know, because most times you get discharged in the past. Patients get discharged. They would not see another physician for weeks or maybe months. But if they run out of medication and they only had a week of aspirin, they're like, well, I haven't taken my aspirin in months. Before, if their follow-up is a month later, they've taken it for a week and they don't know why they're taking it.
Right. They don't know why they were sent home on these medicines following their stroke or following their admission for diabetes. So again, more education is needed, and that's why your early intervention is important.
And that's how we help in decreasing morbidity.
Yeah.
Throughout, right? Oh, look at this. Here's a brother from Napoleon Airline, all the way from Hawaii.
We have a broad reach, Dr. Antoine.
And we've known each other since I was in, what year did I go to Hawaii? 93? What, is it 93? No, 2003. When, 2003? Yeah. Look at that.
Yeah.
Hey, Napoleon, tell Napoleon I said hello.
Hello, Napoleon. Judy says, Dr. Antoine, thank you for everything you're doing for people of Trinidad and Tobago and for your continued sacrifice and service. Winston says, thank you. Let's see here. Winston says, thank you, Dr. Cindy, for recognizing and letting people know who I am. Continued blessings to you for enlightening the info for the people. Thank you. Thank you. For Dr. Antoine. Are they considering the use of the drug interferon in Trinidad and Tobago, as is currently common practice in Cuba, to treat patients with COVID-19? Now, certainly here, interferon is being studied as part of the clinical trials, but I know they also use it for hepatitis C, etc. Is it being used in any context that you're aware of in Trinidad?
No, I truly, I don't want to say yes or no, because I'm not privy to, I truly am not privy to that information. Yeah. Since I'm not involved in treating of any COVID-19 patients.
Right. Pamela says, Dr. Antoine, can you discuss why Blacks may be more at risk with COVID-19? Is it because they are Black, or is it because of comorbidities that predispose them for anyone with these communities that will be at risk? I ask this because there's a wave of fear in the Black community seeking care.
I can answer that in two ways, and I'm sure every doctor can answer that question for you. We live in close-knit communities. We may not be able, first of all, it depends on where you answer your demographics. In Trinidad and Tobago, where we all look, we are primarily 90% of us, or probably higher, of people of color. But if you're answering that, I don't know where that person's from. Where's that person?
I'm not familiar. I don't know where Patricia is, but her picture, I could tell she's of African American.
So yeah, she's in the States. The answer is one, lack of healthcare in the United States for minorities. The close-knit communities they live in. They primarily live in inner cities. All those will cause an increase in COVID-19, in contracting COVID-19. And it's not that they do worse, it's those disparities in healthcare is what causes them to contract the disease versus people who are not of the majority population.
I mean, we're definitely seeing disparities playing a role in multiple ways. So access to healthcare, quality of healthcare, trust in healthcare, meaning the community's trust of healthcare. We're also seeing disparities in people of color who are being tested. And so what we're seeing is more data suggesting that certain people of color, certain communities are less likely to get tested for coronavirus when they present as they're screened. Either the number of tests available aren't high, or they're being screened out and sent home, or their symptoms aren't being assessed in the same way at first. So there's a lot of education there too to try to turn that around. For you, Dr. Antoine, a non-medical question. Have you ever visited Charlottesville and the northeast of Tobago?
You know, I did once. I went there to do an evening question and answers education for diabetes with one of the political leaders who wanted to educate that community. And the answer is yes, I did go up to Charlottesville.
Mm-hmm.
Yes.
Would you go again?
Absolutely. Tobago is small. I'll go. If you send me, look, Cindy, someone knocked on my door a few years ago and told me, grab your stuff. Next week, you will be in Iraq for 50 months. And guess what I said?
Ready.
Yeah.
Let's go.
I said, yes, sir. You tell me today, knock on my door, you have to go treat patients in Tobago, and you have to wear a mask on the plane. And that is a no-brainer for me.
Yes.
I will go.
Yes.
Everyone in Tobago looks like me.
It's true. It's true.
Absolutely, I will go.
I love it. Let's see. We've got more. Laura says, this is very interesting to know because I thought a stroke is a stroke. So I think this is where you were mentioning that there are different kinds of stroke, which again is a big part of, the education.
I understand the question. So this is another point we can enlighten people and help.
Yeah.
So there are different types of strokes. I like to say, the literature doesn't bear this out, but I say there are 3 types of strokes. What we call TIAs, and most people say, oh, I had a mini stroke.
Yeah, the transient ischemic attack. It comes and it goes.
Yeah, it comes in within 24 hours, your symptoms are gone.
Mm-hmm.
There's no such thing as a mini stroke in what I do.
Right.
The likelihood, if you have a mini stroke, the big one is coming again, is very, very high.
It's a warning sign.
Say again?
It's a warning sign.
The reason why you're having a TIA, because something is going on. So you just don't have these symptoms for 24 hours and you just go about your business. We need to find out why you've had this transient ischemic attack or a TIA and treat it like you've had a stroke. You may not have any deficits. You may not have any speech challenges or weakness of the arm or facial weakness, arm weakness, or speech changes 24 hours after. However, we still must treat you.
Yes.
Excuse me.
What could be the underlying cause?
Well, there are many underlying causes. One, your blood pressure, which is rampant in our community. Secondly, poorly controlled diabetes. It can be an arrhythmia, or what we call an
irregular heartbeat.
Irregular heartbeat, or what we know in the medical profession is AFib, which increases atrial fibrillation, not arterial, atrial fibrillation, which we see here a lot. Yes. And it can also be, I did say blood pressure, or if you're a smoker or you're a binge drinker. So those are risk factors that can lead you to have a stroke. Mm-hmm. The second type of stroke is an ischemic stroke, which 75% of most strokes are. That's the blockage strokes. The patient will tell you, oh, my doctor said I have a block, or a clot.
Clot. Yeah, it's either a clot or a blockage.
Yeah, so a clot, right? So that's the majority of patients have blockage strokes. So and out of that 75% of the strokes who are ischemic strokes, most of them will survive.
Yeah.
But they will have disabilities. And those are the people we're trying to capture. And most of those, in America, most of those people will be able to go back to work and have a normal life. Unlike in the Caribbean, not based on my observational studies, 99% of them will never return to work or function again.
And that's because of that aftercare, right? Not having rehab.
It has nothing to do with the stroke. It's one, when do we get care after the stroke? Is it a week? Is it a month? Is it 3 months? If you're getting care 3 months after that episode, the likelihood that you'll ever go back to work is unlikely.
Yes. And then what's the third stroke?
It's hemorrhagic. That's the bad one, right? Mm-hmm. Now, remember, most people who have hemorrhagic strokes do not do well.
And that's what blood birth, essentially.
Yes, right? Most patients who have, more than 75% of the patients who have hemorrhagic strokes will die. The other 25% will have significant disabilities. Very few do well, and we have patients who have done well. And everyone will raise their hand, oh, I have a friend who's had a stroke, a hemorrhage, and done very well. God bless them.
God bless them. And they tend to be younger.
Yeah, and they tend to be younger. They bleed, and it's always bad.
Yes.
And that's when we believe in prayer.
Yes. It's true.
So and people do well, right?
People do well. But again, in early intervention, early rehab is key. Marilyn, for you, she says, what's the difference between a stroke on the right side and a stroke on the left? Okay, so that's an awesome question. If I saw a patient, as soon as they walk through my door and they have they're unable to move their arm on the right or the leg on their right, which means the left side of the brain has been injured. Mm-hmm. So usually patients with weakness on the left or the right side usually also have speech challenges, mm-hmm. right? They're also unable to speak. Not all, depending on where in the brain that was injured. So when you have a stroke on the left side of the brain, the right side of your body is affected, and vice versa. If your right side of the brain, the left side is affected. So those things, so that it makes a significant difference. That's why we need to know exactly with a CT scan, everyone who presents, who comes in the emergency room with a stroke or symptoms of a stroke, which is the FAST, mm-hmm. facial weakness, arm weakness, speech changes. When they show up in the emergency room, we do a CT scan of the brain to see, not to see where the stroke is, Cindy. Right.
They are bleeding.
Yes. And that's the important part.
Different. Mm-hmm. We are trying to find out if so we can tailor our therapies and our treatment mm-hmm. based on if there's bleeding. Now, go ahead. I should have let you finish. You were.
I was going to say same thing. Go ahead. You're good.
So then we need to find out exactly where. And we were in America, most times patients would leave the hospital with an MRI. But throughout the Caribbean, most patients do not get an MRI after strokes. Is it necessary? The answer is probably not. But in the States, almost everyone gets an MRI after that 24-hour window. But almost all the patients in Trinidad and Tobago, we are very good at providing those services. Everyone will get an MRI, a CT scan of the brain. Mm-hmm.
I have to say, yes, from personal experience, I saw what happened with my cousin in Barbados. And once he eventually was found by the right team, he got his CAT scan, he got follow-up imaging, including an MRI. Indeed, he was able to get all that. Here for you, Joan says, great information. She's watching from Los Angeles, California. Hi, Joan.
Hey, Joan, how you doing?
And this, I think, is for you, Dr. Antione.
Hey, cuz great work. Well, I know Richard. Can you hear me at all? I'm sure you can.
Yeah, he can hear you.
Richard's a cousin. He's a registered nurse. He was a medic in the 82nd Airborne. Did some time in Iraq. Just a little shout out to him. He's my I don't know if he went to Afghanistan, but he did some. He's a true warrior, paratrooper from ARIMA. So. Good stuff.
I think, it's so amazing. That's why I love talking with you, because it's always so great to see how many people from the Caribbean, and in this case from Trinidad and Tobago, actually have served in the U.S. Armed Forces, and how many of them actually contributed to the military, not just in Trinidad and Tobago, but abroad.
Yeah, we're trying to get our green cards too. Yeah. And citizenship. I should mention this. Military service by Caribbean people, we go way back. It's 200 years.
True. Buffalo soldiers.
So we've spent a lot of time, and I should say Richard St. Louis is my family. St. Louis is my family name. So he's also a registered nurse now. So he got retired from the U.S. Army, and he's a registered nurse. So
what's his relationship to Philip and Philip's daughter?
Say again?
What's his relationship to Dr. Philip St. Louis and his daughter?
We're all distant cousins.
All distant cousins.
I don't even think I know that's on our grandfather's side. So
Joan is saying, great information, so great understanding right versus left. My brother is fully stroked on the right with effects from an aneurysm, which would mean a hemorrhagic stroke, most likely.
He had a hemorrhagic stroke.
Omar is asking, is there any difference with warmer climates? I'm going to answer this one, and the answer is actually there's no difference in susceptibility. It all has to do with whether or not they lock people down, practice all the things Dr. Antoine was talking about, hand washing, physical distancing, etc. And the prime example is what's happening in Indonesia right now, a very tropical location, and they currently have the highest rates of transmission and deaths in Southeast Asia because of what they did not do. And so, no, there's no difference in transmission. It all has to do with precautions. Dr. Lloyd Brown, who is of Caribbean heritage, but also a transplant surgeon who travels, he works in Rwanda, etc. He says, greetings to you both from a fellow Caribbean, Jamaican, currently redeployed in intensive care unit, managing COVID-19 patients in New Jersey. Great comments, great information, Dr. Antoine.
No, well, thank you for your service, because you doing what you do, you be safe, and we applaud and honor your service on the front lines.
He's pretty amazing. We went to medical school together, so I'm very proud of him. He's one of all my guys who looked out for me. It was amazing. Marilyn, we got, so let's see here. So Dr. Antoine, tell us that phone number again, because I know a lot of people will have questions for you and will need to reach out to your clinic. You said it was 225.
You can post it too. It's 868 225 4120.
4120.
And we'll post the on our Facebook page. We will post the Tobago number, so if they need to call us in Tobago to see us. I will be there next. What date will I be in Tobago? On the the 22nd. I'll be back in Tobago on the 22nd of April.
Of April.
And the 28th of April. So, and if you want to email us, email me. It's G Antoine, GANTOINE at strokediabetescenter.com.
All one word?
All one word.
Now we're starting to wrap up, Dr. Antoine. Are there any particular things that I didn't ask you about? Because you and I, we could talk for days.
I know.
We wanted to make sure the audience heard about.
Dr. Cindy, the number says 868-88-8628.
Oh, I'll fix that.
Okay. So let me say this first. Based upon what you do, and I know I've known you, and I've known your family, and I follow you. Thank you for what you do, and I've seen your other shows, your other segments, and I appreciate what you do. And it's work outside of, people always ask us, where do we find the time to do these things? It's what we do. This is the process, and it's not really. It takes energy and time, but it's what we do. And it's what you do. Thank you for your service doing. Tobago, they should be sending you flowers from Tobago, man.
If they want to send me anything, just send me some pone and cherries.
I think if I ran the show, if I get enough, I would have a parade for all, not only the doctors, but I would celebrate all the people from Tobago who are doing great things, who are willing to come back and serve. Not even just Tobago, throughout the Caribbean, from Jamaica, because I didn't want to call my organization Trinidad and Tobago anything, because we have a lot of Jamaicans in our organization, Trinidadians, and I know Trinidadians who want me to pay them to talk at the Hyatt, and they live down the street.
Yes, I know. So, I think that was the thing that I love about CMP, and not was, but is the thing, because, as Caribbean doctors in the United States, many of us end up operating in silos. And if we met a few other Caribbean doctors, sorry, it's by accident, or you run into them, or somebody says, "Oh, I met someone from your region." In your organization, what was nice is, we met people even from islands that you don't typically run into. So Antigua, you had people in the organization from Martinique, you had people from Haiti, or some of the doctors who ended up being married to someone from another island or another region. And it was tremendous. Dr. Brown says Meliora. Meliora, that is Latin for all the best, which is the greeting from University of Rochester. Omar says, thank you both. You guys are amazing. So appreciative.
Can I say this?
Yes, go for it.
We're gonna, if any providers ever want to practice in the Caribbean, and I always, we need your help, and we make opportunities for people to serve, and we provide a vehicle for you to serve. Yes, there are always going to be challenges coming back home. There are challenges no matter where we go, but we need your help. We appreciate your service, what you do wherever you are on planet Earth, because we've had people come from England on their own dime. We've had strangers contact me from Germany who look like us and came to our Caribbean islands and served for free.
Yes.
And didn't want a penny. So I honor that, and I am appreciative of that. So if you ever want to come home and serve, not just for a weekend, just for a weekend or a week, we will do all the paperwork and help you with that. And
I know that to be true. I mean, it was through you that I was able to go ahead and figure out my insurance, malpractice, all that stuff. You were able to help me with that. So again, I'm living proof that you mean what you say and you produce.
So good. So I am glad that we're here to serve, and we are truly honored to serve, and we have done that. So, and you're doing it now. You're doing it every day.
Yes. Now let's see, who else do we have? Kay for you. She says, "Thank you, very informative." Thank you, Kay, and do please feel free to share the live. Now, guys, we are wrapping up our 1 hour 45. We're getting near. Dr. Antoine, you taught us so much today. I want to make sure we recap some of what we talked about. So today we learned about FAST, and everybody needs to know what FAST means, which is how to look for signs, symptoms of a stroke and act quickly. Do you want to repeat again for people what FAST means and why we should all know it?
So FAST is an acronym that we use to identify if you're having a stroke or someone in your family is having a stroke. F is for facial weakness. For our local people, if your face twisted up. Arm is arm or leg weakness, primarily in the arm, so people have arm or leg weakness. S is speech, if you're having any speech challenges, if you're unable to speak, make words, or your speech is different. Usually, the patient never realizes they're having some speech challenges. It's someone else.
Yeah.
Right? And T is time to call 811 in Trinidad, I believe it is. Or take that person immediately to the hospital. Do not waste time. Do not take an aspirin. Okay. And if you do the nutmeg thing, it's not going to hurt you, but unless it could, unless you're having problems swallowing or I would not recommend a nutmeg.
So you're saying even if they notice this at 11 p.m. at night, 1 a.m. at night, don't say, "Oh, let me go and sleep and I'll go in the morning."
Absolutely not. You go immediately, because most people put it off, right? So the key is to go to the hospital. And you're diabetic. If you're diabetic, make sure you know what your A1C is. You cannot drive this. If you're diabetic, you cannot manage your diabetes without knowing what your A1C is.
Yes. And A1C is a simple test.
Yes. And most clinics now have a point of care machine that we can do A1C in 5 minutes.
Right.
So it's not.
You do. I remember when we did community screenings, you were doing A1C right then and there.
Yeah. So it's we can help patients with that. So this is not. We know the process. So I was explaining this to a patient yesterday. 3 members of a family, all diabetic.
Mm.
And I'm saying to them, we know what if your A1C is 10, we know at some point, if you're 40 years old and your A1C is 10, at some point you will go blind.
Yes.
At some point you will lose a kidney. You'll be on dialysis. At some point you will lose a foot. If you're driving on the Eastern Main Road heading east, at some point you'll end up in a REMA.
Right.
If you're Churchill Roosevelt Highway and you're driving west, at some point you'll end up in Port of Spain. We know where you're going. At some point you can turn off the road.
Yeah.
And as the only person responsible for turning off the road is you. We can help you. So every time you stop, we will give you information to help you turn off the road. Yeah.
Turn off the road meaning reverse the A1C. Now, Curtis is just joining us. Yes. Curtis, we did define A1C earlier, Sandra, but basically we'll have Dr. Antione say again, what is A1C?
Just to simplify it, and not to overly simplify it, the A1C is your average sugar over a 3-month period. When the normal A1C, if you're diabetic, I like to say it should be under 7. If you're not a diabetic, if you get your A1C below 6 is ideal. Mm-hmm. Mm-hmm. If you're higher than 5.7 to 6.3-ish, right, we like to call that pre-diabetic.
Yes.
Right? So, but I like to, people don't remember 5.7s and 6.1s and 6. It's 6 and 7. Because
yes.
Patient may not understand what is 6.7. They don't know what that is.
Very true.
They remember 6.
Marilyn says, on the topic of aspirin, is it still recommended that we take 1 low-dose aspirin daily? There's so many confusing information out there as to whether we take them or not.
That's a phenomenal question. That is truly, Marilyn, that's a great question. Here's my answer. You're just confused as I am. The medical literature says, recently, there has been some challenges. If you're a healthy man, like myself, and you're over 50, some doctors would tell you, you should take an aspirin every day. If you're at risk, if you have family history, if you have high blood pressure, right? However, if you've had a previous ischemic stroke, or if you have risk factors like
diabetes, like your own diabetes, yeah, your own blood pressure,
and then you should take an aspirin. But normally aspirin would not be recommended in a 40-year-old man or 40-year-old woman who is healthy, because the risk can be higher than the value. The risk, comparing risk to value, it may not be worth it. But if you
what is that risk? What are they afraid of, Dr. Antione?
Bleeding. Yeah. The primary risk with aspirin is bleeding, and bleeding in gastro.
Mm-hmm.
So you have your stool turns black. You may vomit up blood, and those types of things. But usually you see some blood in your stool.
But if you have diabetes, if you have pre-diabetes, if you have high blood pressure, you actually are recommended to take a daily aspirin as long as you don't have kidney disease, correct?
Exactly. So it's 81 milligrams, the low-dose aspirin, the enteric-coated aspirin. Do not take the one that's not enteric-coated, right? What does that mean, enteric-coated? It means it slowly dissolves in your stomach, so it does not, it does not irritate your stomach lining. It's not the same aspirin and we do not recommend that you chew it up, right? Because if you chew it up, it breaks down quickly and it can irritate the stomach lining. So we take the enteric-coated 81 milligrams of aspirin, and the literature says that there's absolutely no difference between taking the 81 and the 325, because patients would ask me, I only have 325 milligrams of aspirin. The answer is take the 81 milligrams. It's a lower dose aspirin, decreases the risk and negative side effects of the aspirin.
All right. And, we have some questions. Everybody wants to know, how do we reach Dr. Antione? One question here is asking specifically, where is he located? Do you have a number for him? So I was showing the number. Would you like to tell again where you're located? We talked about Tobago. You're up at Fort King George at the old hospital. at the Stroke Diabetes Center there. But what about Trinidad? Where are you in Trinidad, Doc?
In Trinidad, I am at Piaco Plaza. I'm about 1.5 miles from the airport, right on the Churchill Roosevelt Highway, across from Bhagwan Singh at the on the Churchill Roosevelt Highway. Piaco Plaza, unit number 10, Piaco Plaza. And my number is 868-225-4120.
Yes. And also, if you'd like to reach Dr. Antoine by email, I think we're going to be busy in the next coming days, Doc.
I know. But it's good, you know, because remember, most of what we do, remember, it's also cultural too.
Yes.
Remember, did I talk about vitamin B12?
You did.
Remember, their patients, after they've gotten a stroke, they want it fixed.
Yeah.
You know, my arm is weak, I can't talk. So families do what's expedient. They get B12 injections, and there are people doing that. Does it really help?
Maybe it'll help in the short term, you feel, because some of the placebo, etc., would feel good. Yeah.
But you know, if you give me vitamin B12 now and some steroids, I will feel good for the rest of the day.
Exactly. We feel energetic.
I feel energetic. I feel very good. But ideally, right? So the key here is what we do here at the Stroke and Diabetes Center is education. It's most times we have to educate the patient. We have to find out what caused your stroke, what caused the vehicle to run off the road so it doesn't run off the road again. And that's what we do. And once we get it, we maximize what you have so you can go back to work and return to function with your family, walking and talking and being functional, to maximize your function using an interdisciplinary, multiple members of a team caring for you so we can provide world-class healthcare. And that decreases how many people die from strokes. And the key is there are too many people dying from strokes and diabetes. And we can change. Now, the Caribbean, it's rampant throughout the Caribbean, Dr. Cindy. And not just Trinidad. This is not just in Trinidad, from Jamaica to Guyana. In Guyana, the numbers are awful.
Yeah.
You know, it's incredible.
You work in Guyana as well.
Yeah, I did. I went there a couple times last year, and this year is kind of crazy things going on.
Yeah, COVID. With Rona has basically controlled what we do this year.
Yeah. So, but the key here is we need your help out there. If you're a doctor, a nurse, or a medical provider, physical therapist, occupational therapist, speech and language pathologist. There aren't too many of those specialties here in Trinidad. So we're trying to change it, and we're also trying to provide inpatient rehabilitation facilities here in throughout the Caribbean, so we can decrease how many people are dying from strokes when they don't have to.
Mm-hmm. We have more questions. Oh my goodness, this is good. I have a question on vitamins. Do they help, and what are they? What's needed, since the quality of nutrients in the food we consume is not the same? Marilyn, is this a general question? I presume it's a general question. So if someone were asking you, what can I do as a vitamin, a supplement, an exercise to decrease my risk for stroke, what would you say to them, if anything?
So usually what I say, especially if before strokes,
yeah,
the key is managing any comorbidities, any health issues you have. Diet, exercise. If you're diabetic, we want your A1C down. If your blood pressure, we want that controlled. If you have high blood pressure, you want to.
What are your goals for blood pressure?
My goals is 130/80.
Mm-hmm.
I know that has changed recently, and that's my goal here throughout the Caribbean, and I think that's the
for diabetes, right? Yes.
Diabetes also.
So you want 130 as the top number, 80 as the bottom number.
I try to get that all the time.
Yeah.
And so that's our goal here. And most of the doctors that I work with here, and because I was trained in the States, and that's what I practice.
Those are our guidelines here.
Standard in the guidelines in the States. And that those guidelines are different for England. So
yeah, I noticed that they're different England, and again for PAHO, looking at the Pan American Health Organization, some of their guidelines and recommendations, like they said, they're going for moderate control, not necessarily the tight control that we aim for.
Yeah, for high blood pressure, I like my tight control.
Yes,
and I work for that. It's not always, and I probably will never get that, but that's my goal.
That's your goal, yes.
So,
and I agree with that. I mean, we know that the risk of stroke drops precipitously, right? 15 millimercury, that you can lower that top number to get closer to 130.
And so too with the A1C. So the higher the A1C, the more likely are the potential for strokes. See, the whole purpose of, if there are patients watching, if you know, and again, for the doctors watching, this is Dr. Antione's thing, right?
Yeah.
When the clot breaks off and it travels, when you're diabetic, the clots are a little softer, a little mushier. So the tendency to break off is more likely versus a patient who does not have diabetes. So for every time you decrease the patient's A1C by 1 percentage point, it decreases their risk of strokes, and significantly. So our goal is to get the patient's A1C down to less than 7. And if I can do that especially with my endocrinologist, and I can do it too, but I have a resource that I can go to now.
Yes. And you're a nutritionist.
I'm sorry?
And you're a nutritionist.
And a nutritionist. We do have a nutritionist on staff. But I don't know about you, because you did an MD, PhD, which is phenomenal. I don't know why anyone wants to go to school for so long, but I applaud you for doing it.
I like school. I was doing virology. It was fun.
But, you know, so I'll tell you from my medical school experience at Georgetown, and I can call them out, right? Because I spent a lot of money to go there. So I had 1 lecture in nutrition in 4 years of medical school. That's 1 lecture, which means for each lecture you get 1 question.
Yeah.
So I could chance that 1 question and guess at that question. So which means I'm not reading that whole book, because another lecture will have 20 lectures, and I'm putting all my bets that they'll have 20
questions, right, on the test. Yes.
So trust me when I tell you this, doctors know very little about nutrition. I said all that to say that. So yeah. I know my shortcomings. I haven't employed or hired a nutritionist, a dietitian on staff to complement what I don't know, so she can add value to what we provide for patients.
Yes.
So patients can get the best, right? Because I know I am horrible at nutrition. If you do what I do, you'll get hurt, because I go for 12 hours without eating at times. Right?
Not good.
Which isn't good.
Not good.
I like doing that. I like going long hours without eating, just to try it out. Some people call it what intermittent
fasting. Yeah.
But no one ever told me that was unhealthy, so I did it. So
yes. So I think that's all very important. And Dr. Antione, this has been tremendous. So guys, you've been listening to Dr. Gerard Antione, MD, MBA, physical medicine and rehabilitation specialist, most likely the only one in Trinidad and Tobago, founder and medical director of the Stroke and Diabetes Center of Trinidad and Tobago. He's also the founder and medical director of the Caribbean Medical Providers Practicing Abroad, a non-governmental, not-for-profit organization that really facilitates the interaction and liaison of doctors, nurses, and all allied healthcare professionals who are interested in working in the Caribbean and the British-speaking Latin America as well.
Thanks, Cindy. You're awesome. Keep doing what you do. I'm looking forward to it.
Thank you. Guys, if you have questions, do please send Dr. Antione an email. You can call his office as well. We'll have all this information up for you. Call him, email him, go see him. Guys, he sees patients in Trinidad and Tobago. The rest of the Caribbean, he has telemedicine available. And so there's really no border that can really keep you from seeing him at this point if you have questions. And also if you're just looking for recommendations that are more local to you. Oh my gosh, I was gonna go, but this is a question I think you need to answer.
Do you support the use of metformin in pre-diabetics? The answer is that is a very good question. And that is on a case-by-case basis. So it truly isn't a blanket answer that you can say absolutely or absolutely not or absolutely yes. We have to see what your weight is, because some patients may be 400 pounds and their A1C may be 6.2.
Yes.
They may be 80 pounds and the A1C is 7.6.
Yes.
So that is a very good question, and that has to be evaluated on a case-by-case basis, and you evaluate the patients in their office.
And I agree. As a reproductive endocrinologist, that is my approach as well for pre-diabetics is I look at the story, what's going on. If it's a person with polycystic ovary syndrome, PCOS, trying to get pregnant, so I know her pre-diabetes is likely to become gestational diabetes, I will start metformin, because we know 1 in 7 pregnant women will have issues with blood sugars. And of those women, 1 in 7 who have issues with blood sugar when pregnant, 85% will be a gestational diabetic, which has a host of problems for mom and for baby. And so even though she's young, even though she may be skinny, if she's planning to get pregnant and is pre-diabetic, I'm being aggressive. If she's not trying to get pregnant, but she's older, and like Dr. Antione says, she's got other risk factors. She may be pre-diabetic, but high blood pressure, metabolic syndrome, like we talked about last week with cholesterol issues, etc. This is someone whose pre-diabetes is on a fast track for becoming diabetes and increasing her risk for stroke, heart attack, kidney failure, etc. I'm going to be implementing other things. I want her to lose weight. I want her to change her diet, all that stuff. But I also will be considering metformin. Whereas if someone else is pre-diabetic, but it's borderline, they have never really exercised, they're willing to change their diet, other things seem okay for now, I will start what we call lifestyle modifications. Okay, Dr. Antione, well, thank you so much. Enjoy the rest of your Sunday. I know it's already Sunday night there. Stay safe. God bless. And we'll see you.